that other stuff. So putting them in a regular foster home may not be the best option at that particular time. So they will send us a referral for medically fragile kids with foster care. Any questions about the different services that we offer so far? Sure.
Who decides which is which?
Who decides which is which? Usually with our adult services, usually all those referrals have been coming from the Department of Social Services. With us, with the children's program, we get all of our referrals, and we've got another slide that's gonna talk about that too. Usually they have to be ISADEC approved. Just go out and say, you know, you've got that kid in regular foster care, we wanna put him in therapy foster care. They have to actually staff it, what they call ISADEC staffing. And then from that staffing, they'll determine whether or not they're appropriate for therapy foster care. Because whenever we get a therapeutic foster care client, they come with a contract so that we know that they've already been approved with ISADEC. And usually with therapeutic foster care, not usually, all the time, they have to have a DSM diagnosis. So they're gonna have a diagnosis of either post-traumatic stress disorder, attention deficit disorder, bipolar, schizophrenia, so some type of psychological diagnosis. So that's what you want to see with therapeutic foster care. And again, that's what differentiates, you know, therapeutic foster care and regular foster care. Regular foster care, those kids may not have a DSM diagnosis, they may not have medical problems, and they can be maintained in regular foster care. And only in situations where they can't be, then you'll step them up to therapeutic foster care. So I think you have questions.
Yeah, I've got a boy, a 13-year-old boy, who just went to live with his father. He has not, up to this point, been in his life. So the father's getting used to being a father. This isn't foster care, but it's almost like it because you can child home. But it's almost like it because except dad's not going to be able to give him away when he messes up. And he's been doing that. Would you work with a parent in a situation like that?
We don't usually work with the parents. Usually the referral has to come from an agency such as Department of
DSS.
Mental Health, DSS, DDSN, DJJ. We have to have a contract to provide services for them.
Okay.
Now, I would say in that situation, he sounds like he would be a good candidate to get some support from Continuum of Care. Because Continuum of Care and mental health provides a lot of support to families who kids are in, you know, the home with the biological parent, but they just need some extra support and some help. So I would recommend the dad contact either mental health or Continuum of Care. They both
Continuum?
Continuum of Care. They offer some excellent services.
And their goal is to keep the child in the biological home.
And then in situations where they can't, and the parent needs that extra support and help, Continuum will also pay for their foster care, where the parents still keep guardianship, but they actually place them in one of our homes and Continuum will pay for it. So maybe linking him up with.
I hope we don't go to that. This boy got.
But what Continuum could also do is respite. You know, they could pay for respite. Whereas, you know, the dad may need a break on the weekend. And, you know, I know mental health pays for respite, I think, as well. But Continuum could pay for, if he qualifies for Continuum services, they could pay for respite, which means the dad may get that necessary break that he needs.
Sure. Let's go to that. Good, thank you.
Any other questions? Okay, our client population, I'm gonna turn that over to you.
Okay, like Zeporia said, I'm Melissa Williams. I supervise the clinical staff in our office, and we have 4 clinical coordinators that go out and monitor our cases, either weekly or monthly. The children that we typically work with are anywhere from 0 to 21. More commonly, we get referrals on teenage males around 14, 15 years old. We do have a number of placements that are cross-racial placements, African American children in a white home, Caucasian children in an African American home, Hispanic children with white or African American families. So we've seen a lot of success with our cross-racial placements. We've had a number of mentors adopt cross-racially. One of the things that we do see a need for is Caucasian homes. There's a big need for that. A lot of the times we get referrals in that we are unable to place because maybe the family has a preference for it to be a Caucasian home. So a lot of times we have to turn those referrals over to someone else because we are unable to place them. So if you know anyone interested, give me our number.
Recruiting.
Our recruiting process, our program recruiter does all our recruiting. We have the best success with ads and with our families referring other families. I believe right now we have about 65 mentors, licensed homes.
And that's just in the Columbia program.
Right, and this is just in our office. Our office actually serves, from Columbia, we serve a very broad area. We have homes in Gilbert, Kingstree, down in Orangeburg, Santee, up to Camden, Blackstock, and everywhere in between, Bethune. So we cover a very broad area. I like to think that we have the best families. We hear that a lot from people we work with, and knowing them, and as long as I've known them, I do believe that we have excellent families. There's not a home that I wouldn't want to stay in myself, so it's usually a good gauge. The children, Zeporia mentioned that in order to qualify for therapeutic foster care, you have to have a DSM-4 diagnosis. These are some of the different diagnoses we deal with. Down syndrome, ADHD, post-traumatic stress disorder, conduct disorder, oppositional defiant disorder, depression, mental retardation, bipolar disorder, autism, obsessive compulsive disorder, adjustment disorders. We see some enuresis and hyperesis and our medically complex population. So we have a broad spectrum of different kinds of children. And we learn over the years, I think, we learn with the families, what are good matches for different kinds of children. And I think we have a really good outcome usually.
I would probably say the referrals, we've seen an increase with referrals on children with autism. That's been a big need lately. We've gotten quite a few referrals. And of course, you know, when you're working with children with autism, they like to be in environments that are familiar, so change is very difficult for them, especially in therapeutic foster care. So we've seen an increase in that. We recently placed a young man who is diagnosed with Down syndrome. That was very difficult for him. He was in his home prior to placement. So what we try to do is we try to match the kids up with their diagnosis with who we think that would be most appropriate, the most appropriate home. For example, with our Down syndrome child, we knew that probably needed to be in a home where the primary parent doesn't work, which is the home that we found for him. And somebody that's gonna have a whole lot of patience, because with him, he's nonverbal, so he can't explain what he wants. So, you know, it takes, and it was being in a different environment, coming from home and being, how old is he? 13. Coming from home and being there 13 years into a therapeutic foster home and in a place that he's just not familiar with, that was really difficult. But we were able to, you know, I think place him in the best possible match we have, and he is doing great. So we're very excited about that. And again, I think we have another client that was pretty difficult to place. And how we did that match.
We also have another client placement that Victoria was mentioning that was kind of difficult. And what we did was we knew we had another family in the area. The foster parent was actually a special ed teacher, and so she was used to working with similar types of children. So we link them up with each other to kind of give the new parent support with different kinds of interventions she could use, different things she could try to do to calm the child, to help him. And then she kind of just encouraged her, you know, give it a couple weeks. I promise you in a couple weeks, he's gonna get used to it, and you're just gonna love him. And sure enough, that's the way it's turned out. He calmed down, settled down. He's very used to it, bonded with her now, and just a very loving child.
So we try to link the therapeutic parents up with each other in each other's areas so they can be supports. Because sometimes hearing it from us, it's gonna get better. I mean, we don't have the children in our home, so they wanna hear that from somebody else.
Right.
It is gonna get better, I promise you. So, you know, hearing that from another therapeutic parent who's working with kids with similar behaviors, it's always much better coming from them. So we do try to link them up with other therapeutic providers that can support them.
Right, and sometimes no matter how much education you have, how long you've been doing this, how much experience you have, you don't have children. So, you know, they think you have no idea what you're talking about. So a lot of times it is better to hear it from someone else who's actually living it, doing it.
I have a question. How do these children get to you? Are they neglected and abused children, or, so that's how they?
They're coming through DSS.
Right. The majority of our clients come through DSS, or MTS.
What's the name?
It's a division of DSS,
Oh, okay.
and they deal with the more difficult, severely behavioral challenged children. So, I would say 90%.
I'd say 90%.
Of our referrals come from there. And then we also have some from DJJ that may be just getting released from a facility, and instead of sending them right back into their environment they came out of, they may want to transition them through us to kind of get to learn, and maybe to give it time for the parents to work with the child and get prepared to deal with them when they come back home. So sometimes we deal with DJJ,
And I would just say with our DJJ clients, you know, the agencies are different, DJJ, mental health, DSS, but we also see a difference in the kids. With DJJ, the time that they're placed in therapeutic foster care is a little bit shorter, because usually they're only with us for 6 to 9 months, but usually however long the court order stays, or probation. And then after that, they're gone home, because, you know, the parents have legal custody, so they usually go back home within 6 to 9 months. With the DJJ client, we usually see more of the conduct disorder, more so than the emotional abuse and problems. It's because they're misbehaving in the community due to usually lack of supervision. So from that, they may sometimes get referred to therapeutic foster care because they're not ready to transition back home. With DJJ, we see clients that are sex offenders, that are registered sex offenders that we have placed in our program. From conduct disorder to a lot of drug and alcohol abuse, I think is what we see a lot with the DJJ clients.
Now, what if they have been placed in a therapeutic foster home? They don't have a family to go back to. Where do you put them?
if they don't have family involved, or in the case of if their parents' rights have been terminated, the plan may be independent living, so we may be trying to prepare them to live on their own, to either go to college or some sort of vocational training, as they get older and age out. We try to prepare them for that. They may be up for adoption. Some are open to that, and some are just like, I don't wanna be adopted, so the plan may just turn into permanent foster care or independent living.
And usually we know what the plan is when they're referred to us. DSS, if it's a DSS kid, I'm sure all of you know with CASA, usually they have a plan with what they wanna do. It may be return home, it may be permanent foster care, it may be adoption. It's usually one of those three things, or independent living if they're like 17 or 18.
Yes.
So, you know, usually we know what the plan is and we try to work toward that.
Well, and the nice thing that I get to see a lot, working with the clinical staff, is in cases like that where the children don't have family to return to, they may, this mentor foster family becomes their family, And that becomes a place that they leave off and go to college from there. When they come home during breaks and stuff, that's where they come home to, is back to that home. It's very common for our former clients to maintain contact with the families that they've been with in the past. So it's a real good
And
possibility.
sometimes the plan will change, and I'll give you a quick example of that. We had 2 clients to come from New Jersey, the state of New Jersey, and the plan was for them to be reunited with their family here, their dad here. And that didn't work out. You know, after being here for a few years, dad wasn't compliant with the treatment plan, wasn't coming to see them. And you know, after so many years of trying to work with the dad, you know, finally their plan changed from family reunification to independent living, because at that particular time, they were 18. So we have continued to, you know, we were able to keep them in the program, and one of them has turned 21. So, and he's still residing with the family that he came with 7 years ago that we placed him. He's still there. He's a part of their household. That is his mom, his dad, and then the other young man, his brother, because we ended up having to place them separately, is also with that particular family and calls them mom and dad. And they get to visit each other, and the families are very close. But the plan does change occasionally. Sometimes it's family reunification, and then if the parents aren't compliant with their treatment plan, it can often change to independent living, adoption, or permanent foster care. So every now and then, especially with our medically fragile, we may get a baby in, and the plan may be, because normally when you get a baby in, the parents, you're always going to do, you know, return home, at least for the first 6 months, year, or however. Give the family, the parents a chance to, you know, do whatever they need to do in terms of working the treatment plan in order to get the child back. But in some cases that doesn't work. Families don't visit, you know, the babies eventually grow up, and then, you know, they do the TPR and adoption, and a lot of times our therapeutic parents will adopt. We've had quite a few adoptions, especially with the little ones, where they just can't part with them, and those are all the family that those babies know. I mean, can you imagine trying to move a 1 or 2 year old to another home? How hard is that? So, you know, a lot of times our families get very attached. And even with all the kids that we have seen to grow up and leave the program, they always call back. Every single one of them, I think, just about. They always call those families back and talk to them and remain connected to them. So I think that's very rewarding for the therapy parents.
Right, and sometimes we have to remind them that, don't hang in there, I promise you one day this is good. But it does inevitably turn out that way. And Zeporia had mentioned about some of our families and the connection and everything. I just wanted to talk real briefly about one of our just outstanding families down in Manning. And they have had this young man since he was 1.5 years old. He was abandoned in the hospital by mom. He had a lot of medical problems. She still has him. He is now about to turn 11 this summer, and that is her baby. He is nonverbal. He has a G-tube, a trach, nebulizer. He has to have oxygen during the night. He has very little movement. So basically, she took him in at 1.5 years and has always provided for him 24/7 every need that he has, taking him to appointments, medication around the clock. She has to get up during the night and administer medications during the night. G-tube feeding. I mean, her complete lifestyle had to change because all of a sudden she's at home caring for this person all the time. So the commitment that we see a lot of times from the mentor families are just overwhelming. And we do see drastic changes, not just for the children, but also for some of the families. But just one of my most favorite little clients. But behaviors we typically see are a huge range. We see some physical aggression, or they may have a history of physical aggression coming in. Once they're placed with us, we don't see that much physical aggression, believe it or not, which is wonderful for our parents because we don't want them to have to deal with that. But they may have a history of it, especially if they're coming from a group home setting. They may have a history of physical aggression with staff there or with their peers. So that's something we definitely want to take care of initially. Verbal aggression is pretty common, and we a lot of times have to remind the mentors to ignore a lot of that. Sometimes kids just need to vent verbally, and it's best to let them do it, get it out. Sexual acting out, we do see that.
We tend to see a lot of that when we get a referral on a child that might be 5 or 6. We tend to see a lot of the sexual acting out behavior, and that's why they're being referred, because they're touching other kids inappropriately, and they're usually exhibiting those behaviors because they've seen those behaviors somewhere, they've been exposed to it, that it's been done to them, and they think it's normal. So a lot of times when we get a referral on a 5 or 6 year old, a lot of times they have some sexual inappropriate behavior going on and cannot be placed in a regular foster home, because again, you in a regular foster home, sometimes you'll have some other children there, and you can't put them at risk to touch or victimize, another kid. So with the little ones, and a lot of times when we used to get referrals and read the information, and you see, oh, this is a 5-year-old, this is gonna be great, and you read it, and some of the behaviors and some of the things they're doing and have been exposed to and have been done to them, it's just very sad, very sad. So we do tend to see that a lot sometimes with our younger children. And then we'll see some of the sexual acting out with our older children that are promiscuous, that have been, sexually abused as a child, and, act out by just being promiscuous a lot of times.
In these cases, we definitely try to find a home that doesn't have other children in it to place those children, because we are very concerned always about not setting the child up to act out, not giving them access, and then also we're concerned about the mentor families, children and grandchildren, and we don't want anything to happen to them. So that's something we try to do to prevent that.
What do you do with a child like that, say they're 12, 13, something like that, and you get them, do you teach them about sex or talk with them, or do you just put them in the home? What would you do?
Well, typically, they would have pretty intensive therapy, and we would have them see a therapist that specializes in that particular kind of behavior. Usually, weekly therapy is something they're involved in. And then also, all the while, we're working with them on appropriate boundaries and
I have a child that I'd love to see.
And I think a lot of times with kids like that, the therapeutic parents are really working with them on boundaries. Because with our kids that have been sexually abused, usually, they will go with any and everybody. You can just grab them by the hand and they'll go with you. They want to hug and kiss constantly, or they want to touch you inappropriately. And there's a lot of redirecting that the therapeutic foster parent has to provide. And the other thing is, what's real important too, when we have a kid that's been referred that has sexual issues, is placing them in a match. If we have a teenager that has sexual acting out issues, we're not likely going to place them in a 2-parent home where there's a male in the home, because we don't want her to maybe try something sexually with the father in the home. So sometimes when we have a young lady that may have some severe sexual acting out issues, we would try and find them a single parent home, which may be a lady. And a lot of times MTS or DSS will say this child needs to be in a single parent home. She's got a lot of sexual issues. She's very provocative in her attitude, her dress, and everything. And we tend to take all that into account, because one of the things we don't want to do is we don't want to set our therapy parents up either. And so we try to make sure it's just the best possible match. We would never place a teenage girl that has sexual issues in a home where they have a teenage son either. I mean, that's just like, just pouring fuel on fire. You're setting, so we try not to set our parents up. We try to look at the whole situation and then look at the families that we have and match them appropriately. Because if they're matched appropriately, the likelihood of success is going to be greater. You match them inappropriately, and then you're going to have an explosion on your hands, and it's just cleanup. It's just horrible.
Do you do the same thing if they're males? Because mine's a male.
Mm-hmm.
Try to get them in. Would you try to get them with this a single male?
If MTS required that, we would.
Yeah.
Mhm.
If not, then it would just, would you put a male in a couple, a man?
We probably wouldn't put a male with sexual issues with a single lady, but we would probably more than likely do it in a two-parent home and have the male of the house kind of supervise him a lot. We try not, kids with sexual issues, we try not to have, say for example, if it's a teenager, we try not to have the dad unsupervised with the female at all. You know, we just try to make sure that there's a safety plan in place. When you understand this kid has sexual issues, you know, this is what you need to do in your family home to protect them and to protect yourselves. So,
Are there very many single male homes, foster
we
homes?
have one right now. And we've had one in the past who's done a really good job for us. We actually had some kids in our program that were adopted by a single male. It wasn't one of ours, but was adopted. So every now and then, we'll get a single male that may come in that's interested. We're very excited about this gentleman. He is wonderful. He has a daughter of his own. And he just wants to be a therapeutic parent. So we're very excited about having him on board. It's rare, but every now and then. We get more single ladies and families than we do single men.
Some of the other behaviors we see, runaway, that's pretty common. Stealing, lying, oppositional behavior, alcohol, drug abuse, problems at school. I would say the majority of the incident reports we have to write are on school suspensions. We see a lot of those, and hyperactivity. Typically our kids are they're usually not gonna exhibit their behaviors at home and at school. It's usually one or the other. So, it kinda helps us know what kind of family we need too. If they're mostly having problems at school, we're gonna need a family that one of the parents is gonna need to be able to go down to the school frequently to attend meetings and pick them up early and supervise them while they're suspended. And so,
sometimes we're fortunate enough to get schools that'll really work with us. And I think a lot of times and we encourage our therapeutic parents to go to school, be friends with the principal, everybody at the school. Because a lot of times when they would normally kick a kid out, if they know this child has some special issues and circumstances, they will work with the parents and the kids a little bit harder than a parent that just doesn't go and the kid is acting out. So we try to encourage our parents to go to the school. They spend a lot of time at the school talking to the teachers and the principals, and we're able to get our kids maintained better in school that way.
and my clinical staff, my coordinators try to maintain, especially the kids that tend to act out at school a lot, maintain close communication with the school as well. Participate in those meetings as well, so we can as a team come together and try to figure out what's the best interventions at school for this child. How can we get this child through school successfully and prevent them from being expelled or kicked out, and have to look at alternative school settings.
Yeah.
Okay.
Yeah, school is pretty difficult for our kids. What we see a lot just on the school situation is for some reason our kids tend to gravitate toward the kids that are more negative a lot of times, and tend to get into, they're easy targets a lot of times for gangs. We're having to go to a gang meeting on Monday because, we have this kid and he just wants to be accepted, he wants to be liked. And when you think about that, that's what these gangs are looking for. They're looking for easy targets. What they sell is, we will be your family, we will be your best friend, we will protect you no matter what. So you have a kid that's in therapeutic foster care that don't have their biological family, has had so much turmoil in their life. A gang seems very appealing to them because this is going to be a brotherhood or a sisterhood, and they're just going to fight for me and do whatever. So we have seen a problem with that, and we really had to work on dealing with that and get training with how to identify, gangs and paraphernalia and all those things. So we've actually provided some training, awareness, I said not training, but awareness to our therapeutic parents on, gangs and things like that. So always very interesting. We talked already about the referral source, where we get our referrals from. We don't get a whole lot of referrals from the Department of Mental Health. Every now and then we do. With mental health, again, the parents are the legal guardian. That's what makes them different from, of course, DSS. And with the DJJ, I'd say we get We don't get as many referrals, of course, again, as DSS from DJJ, but the referrals that we do get, again, are gonna be your conduct disorder children usually, and they're, again, are returned within 9 months. With our DJJ kids, I think they're so interesting because, again, a lot of it is supervision with our DJJ kids. A lot of it is just that there's no supervision at home, and when there's no supervision at home, they tend to run in the streets and just get into a lot of trouble. And when they get into trouble, of course, you'll see them in the court system, they're at DJJ, and then they're usually referred a lot of times for placement. With the intake process, we'll get a call from any one of these agencies, and what they'll do is they'll send us a referral application. We'll review the referral application. Sometimes we go out, we meet the children. Sometimes we do what we call a matching, a pre-placement visit, where we'll match the children up with a potential therapeutic parent, and they'll do maybe a weekend visit. Sometimes we have the luxury of doing that, and sometimes we don't. Sometimes DSS is in a real bind. You know, they have a kid sitting in their office, and I know if y'all are over at DSS, which you're over there a lot, you know sometimes the kids are sitting in the office and they need a place to go quick, fast, and in a hurry. So a lot of times we don't necessarily have the luxury of doing a pre-placement. We just have to go immediately, you know, for a placement. But we use, again, the matching process, we try to take our time and look at the referral and place them in the best possible home that we think is gonna make them successful. So we do take our time and we do discuss who we've got available, the behaviors of the kid, the dynamics of the home, and if we think it's gonna be a good match. Okay. Just with our treatment process, with Mentor, we have 2 consultants. We have a psychologist consultant that comes in weekly to staff cases with our clinical staff, and he also provides training occasionally for our therapeutic parents, which is really good. He also reviews our treatment plans, but it's good to have him come in. His name is Dr. Holmes. He's with Hall Institute, has been with Hall Institute and USC for, I don't know, probably 30 years. We also have a nurse consultant that comes in probably on a monthly basis now to staff our medically complex cases with us, because we have to staff those cases to find out if there's anything that we need to be doing differently in terms of their treatment. So we're very fortunate to have 2 consultants on board, and that's our nurse consultant and our psychologist consultant. We develop what we call an individualized service plan for each one of our clients. So when they come in, we write a plan that's going to be specific for them. In terms of role of the therapeutic foster parent, we ask them to provide what we call a structured day. They document how the kid is doing in their home. We ask them to make sure that you sit down with them on a daily basis and process with them. Find out what's going on at school. Find out what's going on in their head. Just talk to them. And if you sit every day and talk to them, you know, it'll be amazing what kind of information they'll find out, or how much that kid will begin to open up and share. So we do talk a lot about the structured day and things of that nature. The role of the lead clinical staff, which is the LCS, we have coordinators or caseworkers that actually go out. And you all may have heard, I don't know if you've heard DSS talk about the levels of kids, but with therapeutic foster care, there's 3 different types of levels. There's level 1, there's level 2, and level 3. Level 3 being the most severe and requires the most supervision. Level 1 being the least severe of the 3. So depending on the level will require how much therapeutic, or how much the clinical staff is out there. If we have a level 3 or a level 2 case, we have staff out there every week doing a home visit. We have them out calling once or twice a week just to do phone contact with them to see how things are going on. If this is a level 1, we're doing weekly phone contact and monthly home visits. We also have staff that's usually on call 24 hours a day. So that's pretty much the role of the clinical staff. And also just coordinating all the services the child needs. That's the role of the staff. They work very closely with the therapeutic parent. And then we also just have what we call a multidisciplinary team approach. Whenever we have a team meeting to discuss the individualized service plan, we ask people from the school to attend, we ask the therapist to attend, we ask the biological parents to attend. If the plan is return home, they're more than welcome to come. And any of the caseworkers, whether it's DDSN, DSS, MTS, we always ask them to attend as well. So we like to take a team approach to it, making sure that everybody has a say, and we also, most importantly, have the client there to talk about their goals. And just some of the supports, I'm not gonna go through all of these. I know, I got my phone out so I can keep track of time, because I know we only have an hour. But these are just some of the things that we provide. We have our own trainers in-house. Melissa, for example, is a CPR instructor as well as a restraint. She also does non-violent crisis intervention training, which teaches you about restraint and the proper way to do restraint. But we train in-house our own therapeutic parents. We provide all of that. We're also on call 24 hours a day. So if there's ever an emergency, we're always available. We also have a quality improvement supports where we have somebody checking our files, making sure we're doing what we're supposed to do. And just providing community training, such as gang trainings and things like that, getting people in the community to come in. And then, of course, the discharge goals, maybe family reunification, adoption, permanent foster care, independent living, and I think we've talked about those. I did my own applause. Just in case y'all didn't know, I did my own applause.